there's a lot of curiosity about cannabis. There are about 13 psychoactive substances within cannabis, but there are two main ones, and the main ones we talk about are THC and CBD. Let's move forward. What are some of the differences between them? So THC is largely acting with endocannabinoid 1, or cannabinoid 1 receptor, and it does have big impacts on anxiety, big impacts on mood, but they are, we think, therapeutically limited. This is a hot debate, and I don't think we can say yet. I will say that I, for one, am glad that it's finally being thoroughly investigated in a rigorous manner, because basically before we had the scientific community largely ignoring it, and we had the community out there at large using it, saying it's fabulous, and we had no actual study going on. So I am glad that it's being looked at. We know that it can cause psychoactive and hallucinogenic effects, and there is a lot of concern as to whether it may worsen the risk of psychosis, especially in people who are at higher risk, like first-generation relatives of schizophrenics. I myself feel that cannabis as an anxiety med, that's where it's largely being used in psychiatry. I personally predict, you can hold me to this 5 years from now, but that cannabis right now, THC, is where we felt about Valium in 1973. That it is absolutely wonderful, and we have not yet discovered that it's going to cause some real problems when you've got people using it chronically over a long period of time. That's my thought.
So, Dr. Mills, let me actually chime in here a little bit, because you brought it up regarding cannabis and anxiety. And as you know, I think this is a very hot topic these days. There's the issue of cannabis becoming legalized in many of our states. Patients and people utilizing CBD for various disorders. It's interesting, actually, one study that showed CBD could potentially help with anxiety was a small N numbers, and they used it at 400 milligrams.
Yeah.
Just to put it in perspective, the CBD oils that are being utilized these days, they're usually sold at a 10 milligram per ml vials, and they're about a 10 ml vial. And the recommendation is to take 10 milligrams. So yeah, I usually warn my patients regarding the placebo effect, that the study showed 400 milligrams, and what they're purchasing is only 10 milligrams. So
CBD is a very different compound. It is still within the cannabis plant, but it has a couple of different actions. A lot of them probably we don't know yet, but it doesn't. One thing we do know is that it doesn't have a lot of action on the cannabinoid 1 receptor. And for this reason, I am, I have a lot of patients who are interested in trying CBD. They're being put on it by their pain specialist for their pain syndrome. They're being put on it for various other reasons, or they're just buying it at the gas station for their anxiety on their own. I myself am not necessarily squashing them as hard in terms of CBD as I do with THC. I personally am trying to steer people away from THC, and I'm kind of just taking a more neutral approach. I do think it needs to be studied more, but we know that it's non-hallucinogenic. It does have some activity at the serotonin 1A receptor, which is known to be possibly a good target for adjunctive treatment of either anxiety or depression. There have also been some, again, small studies looking at it in schizophrenia, and again, in higher doses than people would usually use. But it is interesting, and I am glad it's being studied.
In continuation of what you indicated, actually, it is true. Cannabis has been utilized, probably the second oldest drug that we've utilized in history. And interestingly enough, statistically, countries with highest use in 2018 were Zambia, US, Canada, and Nigeria. But in 2016, 51% of adults reported a lifetime use of cannabis. So very common. 2013 data shows about actually 2.7 to 4.9% of global population ages 15 to 65 utilizing cannabis. And as indicated earlier, it just has an inhibitory effect. So it actually works through a retrograde signaling effect. And the main difference between THC and CBD is actually, for us psychiatrists, sometimes a little bit easier to understand if you look at what receptors it affects. So some of the ones that are actually of interest to us, THC tends to affect CB1 receptors are mainly in central nervous system. CBD, CB2 receptors, mainly peripheral, and they are found in hematopoietic system. Interestingly enough, THC is a partial agonist at CB1 and CB2, versus CBD has a negative allosteric modulator for CB1 and weak antagonist at CB2. When it comes to 5-HT1A receptors, that we know actually plays a role in regulating serotonin and downstream dopamine levels, THC itself has no effect on 5-HT1A. However, CBD is a full agonist at 5-HT1A receptors. At 5-HT2A receptors, THC has no effect. CBD plays a weak partial agonist at 5-HT2A, and 5-HT3A receptors, THC has a negative allosteric modulator effect. Same thing as CBD. However, where we see a little bit of signaling of CBD in psychiatric disorder, maybe treatment of depression, maybe treatment of even schizophrenia, there's some signal, because it is a partial agonist at D2 receptors. So maybe that could play a role into some use in those disease disorders. So, Dr. Nelson, any other comments on the differences between these two compounds?
No, I mean, it's just important for us to note that they are very different compounds. And from a practical point of view, we definitely want to think about that when interacting with our patients, because especially in a state like, in Pennsylvania, it's legal. Medical marijuana is legal. So, I mean, whether I like it or not, I have patients who are on one or the other. And it's important for us to know the differences between them, especially in terms of how much has been studied with each one.
Yeah,
cocaine is a lot more straightforward. Cocaine is specific to the dopamine transporter for the most part. It does also have impact on the serotonin transporter at various ratios. It is, but if we think about its addictive potential, I think most people agree that that is primarily through its impact on blocking reuptake by its antagonism of the dopamine transporter. So that's what you see on this slide. We see a whole bunch of dopamine receptors on the pre- and postsynaptic cells. They're showing mostly D1 or 5 receptors presynaptically, and then they're showing a variety of, usually you wouldn't have both receptors on the same neuron, but it's just a cartoon. And then, this slide shows the dopamine transporter being blocked by cocaine, and therefore the dopamine is trapped in the synaptic cleft, having greater impact as it sits there. Interestingly, now another important thing to note about cocaine is that it's also a sodium channel blocker, and that would, some of the original study into cocaine was not snorting it, but using it as a local anesthetic. Sigmund Freud himself was experimenting with this. There are interesting stories about people putting needles in eyes and such. So it's useful for that. Of course, we usually use other local anesthetics or sodium channel blockers, but a lot of them are based on the same chemical principles as cocaine. What are the actual statistics on it? In terms of addiction, at the 2-year mark, if you've been using cocaine even just recreationally for 2 years, you've got about a 5% chance of developing dependence. If you use cocaine for 10 years, your rate goes up to about 15%. So it is one of the drugs that has a fairly high rate becoming an actual dependence, and reaching those levels where you're really having an impact on people's lives. Now, of course, opiates are a very complex mechanism. Here we see opioids in their impact on the dopamine pathways, so I'm assuming we're in the nucleus accumbens, although the slide doesn't say. Opioids themselves mostly act through opioid receptors, and of course there are somewhere in the teens in terms of number of opioid receptors now. The main ones, of course, are mu, kappa, and delta. Those are the main classes, but they've come up with somewhere in the ballpark of 15 to 18. It sort of changes back and forth if you Google it on any given day. So we know that opioids have a couple of main effects. What are the main effects? In the mu receptor, we know that they are largely responsible for pain reduction and for a sense that everything is going to be okay. Those are the two main things, and that would largely be the mu1 receptor. Mu1 receptors are what you see primarily in the brain, and so that's where you get analgesia, above the spinal cord, basically. And then mu2 receptors are in the rest of the body. They are are largely responsible for things like respiratory depression, and for a lot of those physiologic dependence symptoms like the goose flesh and the diarrhea and sweating, etc. Those are mu2 receptors would be largely responsible for that. Kappa receptors are largely responsible for sedation, and they are also where you get analgesia in the spinal cord itself. So there's different receptors, different opioid receptors, and they are working both within the brain and in the spinal cord. So what do opioid receptors do? They have a number of different activities, and I really can't go into, we don't have time to go into all of them now. What I will say is in the nucleus accumbens, it's really important to note that it is absolutely increasing activity of dopamine, probably through opioid molecules' impact on presynaptic GABA. So it will suppress presynaptic GABA and therefore excite the neurons. Often that will lead to increased dopamine release, and that would cause increased postsynaptic dopamine signaling in the nucleus accumbens. So they definitely do have a direct impact on the reward pathways, dopamine pathways in that area of the brain, the reward center.
Dr. Nelson, can we conclude that the common denominator to drugs of abuse, and especially the ones we have reviewed, is either direct or indirect increase in dopamine in nucleus accumbens?
I think that's pretty much a given. And what I really loved from what you were saying before, that these are central, these are subcortical brain structures. And I bring that up with addiction patients all the time, that if the thinking part of your brain had anything to do with this, you would have this under control, right? This is something where some substance has hijacked a portion of your brain that's responsible for decision-making processes that you are largely unaware of. And I think that's a really powerful concept for a lot of people with addiction.
And it's important to understand that. So with that said, so let's keep that in mind, and let us now take a look as well. So what happens to someone who abusing alcohol, and how could that potentially affect and bring it back to the topic of our discussion today, to MDD symptoms? But again, when we just kind of remember the neurobiology that we just quickly reviewed, increased dopamine receptor activation in the reward pathways leads to decreased dopamine levels with chronic use. And there's adjustment of the dopamine receptors and the density of the dopamine receptors. We know alcohol may affect the production and activity of MHTFR, which reduces the availability of L-methylfolate, which is essential to synthesize monoamines in the brain. So by just virtue of exposure to it and the pathology, physiology of alcohol, we can see that there could potentially be changes in the neurotransmitters. There could be the reduction of serotonin levels, could be changes in the dopamine levels, which eventually will result in depressive symptoms. Same thing with cannabis disorder in a different mechanism of action. But the question usually is chicken or the egg thing. So was this the drug or alcohol? Was this the cannabis that precipitated the mood episode? Or these patients were actually depressed and then they started to utilize alcohol, cannabis, cocaine, opiates to make themselves feel better? Well, usually, sometimes it's hard to answer that question. Sometimes it's a mood episode that prompts patients to use, and sometimes it's the use that prompts patients to mood episode. So going back to Dr. Nelson, if you'd like to tell us a little bit about cocaine and opiate effects.
Yeah, well, and just to comment on what you're saying, yes, that's why they call it dual, right? This is why it's called dual diagnosis, because treating either one of them in a vacuum is half-baked. Right? We absolutely need to be treating these things simultaneously. And I agree. It's a really hard chicken or the egg question. Somebody comes in, let's say you're working residential rehab. You have somebody come in and their mood, they look like death warmed over, but you're trying to do this sort of thumbnail sketch of, is this one of the ones who's just going to get better spontaneously while they get with their groups and get clean? Or is this somebody who 3 weeks from now I'm going to be kicking myself for not starting them on something, and because they still feel so terrible despite the fact that they're 3 weeks clean? And I'll tell you, I mean, I try to do my best, sort of actuarial job of figuring out who needs the meds now, who shouldn't, who should I hold off on? And I think I'm probably wrong a quarter of the time. I don't know, what's your experience with that?
So, I agree, because, if you look at, again, that's why I emphasize that the common denominators increase dopamine. Once patients stop using, there is a decreased levels of dopamine. And this is a brain that is being used to significantly higher levels of dopamine. I usually use a driving analogy that if I'm going at 100 miles an hour, when I slow down to 50, it feels really slowed down. So that is what's happening in our patients' brains, that they are going to experience dysphoria. They're going to experience depressive symptomatology. And I'm a big proponent, as what you said earlier, that we need to be prepared to treat that simultaneously in the same spot. At the same time, the traditional approach used to be that, okay, we need to have patients off their drugs and alcohol for at least a year before we can accurately diagnose them. And I think that still holds true. But again, we have to be able to get these patients to that 1 year mark off their drugs and alcohol. Again, as you said earlier, that when patients start using, that becomes a coping mechanism, and then they stop developing other coping skills. They don't have coping skills. Now their dopamine levels are lower. They are just having a very, very hard time dealing with life and anything that comes their way. So we have to be prepared to take care of them at that point.
No, I totally agree. We can't be waiting a year to treat a lot of these people. I mean, it would be wonderful if we had some mythical farm in Iowa to send people to just get clean for a while. But, we in the real world, we do need to be treating these symptoms as best we can so that we can get them, keep them on the road to recovery long enough for their brains to calibrate. But anyway, moving on to cocaine. So, we talked about how it works directly on dopamine. It also works on serotonin, to some extent norepinephrine. And so this is probably one of the more direct impact molecules on the nucleus accumbens, on the reward pathway. And just like everything else, we do see, with it, a significant increase in activity, and then in its absence, a significant decrease. And we see this blunting over the whole system. So, we definitely see, as we see the impact on MDD symptoms, that heavy use of stimulants with like cocaine, or I would add meth, is very similar. There's some differences between the mechanism of meth and cocaine, but they're similar enough we can kind of put them together. And you definitely see anhedonia, lack of motivation. The other thing we should note is that with most of these drugs, while you're using them, you're also not exercising. You're also not eating well. So there are a lot of secondary reasons that these things can impact, impact mood. The same thing you see if we move on with opiates. We talked about how they act on the mu, delta, and kappa receptors, and how this does impact the nucleus accumbens VTA, nucleus accumbens reward pathway. And so, yes, I no joke, you hear people talk about it being up to 2 years before they feel like their brain is really what their brain used to be again. It may take that long just for testosterone levels to rise again, right? We should not forget that opiates especially, but some of our other drugs, cannabis and alcohol, there's some implications of this too. You get lower testosterone levels, which can have a significant impact on people's moods and other aspects of depression.